Without notes, I will cheat and use my notes. Thank you all for being here and sharing in this community networking event with all of us. I'm going to have the honor of briefly introducing our speakers, and I'll ask you all to come to the stage one at a time. Let's start with Charles Brown. Come on down. Dr. Brown is an associate professor of health sciences at TSU. He's trained as a behavioral scientist and works as a program evaluator for numerous community-based programs. And he's going to be sharing with us one in my hometown of Chattanooga, working on health literacy in the community members. But he's really worked with a lot of local and state agencies, academic researchers, and nonprofit organizations to cover a whole array of public health topics, ranging from alcohol misuse screening to depression screening and other preventive services. Our next speaker will be Dr. Stephen Patrick. Dr. Patrick, come on down. He's the William Long Director of Child Health Policy at Vanderbilt and directs the Center for Child Health Policy. He's also Executive Director of Firefly, which is a wonderful community-based program providing services to mothers who have opioid use and their infants. He's done a little time at the White House as a health policy fellow and has also worked from time to time as an attending neonatologist at Monroe Carroll Jr. Children's Hospital at Vanderbilt. And I don't know how he has time to do this, but apparently, I just found this out, he's a health policy researcher at RAND as well. So somewhere between those three jobs, he's found time to spend a little bit of his evening with us and is going to be talking about his community-based research on maternal fetal health. Our third speaker, Chad Curtis, come on down. Chad's a licensed social worker, certified trauma specialist, rainbow advocate educator, peer recovery specialist, and founder of our state's first and only LGBT plus recovery residence, We Are One Recovery. He sits on the mayor's LGBT Leadership Council and has worked extensively in the recovery community with 10 years clean and has been a keynote speaker at numerous conferences. Really looking forward to hearing his experiences and insights as well. And our moderator for today, Dr. Karen Wingfield, needs no introduction. As Executive Director of the Meharry-Vanderbilt Alliance, she's the glue that keeps this community together. And she'll be helping us learn from all of our speakers today. So Dr. Wingfield, would you like to join the stage now or a little bit? Okay.
Go ahead with your
All right.
talks. Yeah.
Okay.
Here.
So actually, I think Dr. Brown, you're first, right?
There you go. Should be the next slide.
All right. Let's see here. All right. So it's a pleasure to be here with you all this evening and being able to kick off our speaker presentations tonight. I've been invited to talk briefly about my work in the health equity field. And for many years, I've served as a program evaluator. And I'll be talking about my work in the evaluation field as it relates to evaluating community-based programs. And
Too well. Let's see if this is on.
I'm sorry.
Oh, that's okay. Is the mic on?
Can you hear me?
Well.
No?
Can you hear back there?
I'm sorry. It's not. Oh. Oh. Testing. Oh. Yes. I'm sorry. Yeah. Okay. All right. So, again, I'll be talking about my work and working in the health equity field. And for many years, I have been conducting evaluations among many community-based programs. And many of the programs have been designed to reduce health disparities and advance health equity. Oftentimes, I share with people that I am a program evaluator, and the first question I get is, what is evaluation and what does that entail? And so I like to first start off by saying that program evaluation typically has two components to it. We have what is called a process evaluation, in which the program is designed to assess whether or not the program is meeting its intended goals and objectives. And also it has an outcome evaluation in which the program is designed to test the level of effectiveness among participants and patients. These two components you can find in just about any program evaluation. They're your basic evaluation components that you'll see out there. And I believe evaluation is essential when it comes to developing programs and helping to advance health equity. My experience have been helping to design strategies to help programs achieve health equity, and also develop measurements that will help to collect data and also help to obtain data among hard-to-reach populations. And then ultimately, we hope to see some kind of changes as it relates to different policies in the community, and also help to establish guidelines to help promote equal access to care. So advancing health equity is at the top of my work that I strive to do, and evaluation is a key component of that process. And so I'd like to talk briefly about some of the programs that I've been involved in over the years that it has entailed health equity. And one of the programs I'd like to talk about is the Health Literacy and Health Equity Program, which is conducted in Chattanooga, Tennessee. And this particular program is conducted through the mayor's office. The mayor in Chattanooga established a community health department, which was not in existence until 3 years ago. And this particular program that I'm talking about today is basically the core of that particular office and program. And so the office has been established to help promote health literacy, and the office have identified several communities that have shown low health literacy levels. And so the program is implementing a health literacy intervention within several communities at local churches, community centers, and senior citizen facilities. The city has hired nurse practitioners, community caseworkers, and also social workers to come on board to help deliver the services within the community. And so the healthcare providers and caseworkers have been trained in a health literacy intervention, and so they are using the intervention as a part of conducting their services when it comes to providing vaccinations or testing or interacting with the community in general. And so patients are interacting with healthcare providers. They're getting the chance to ask questions about their own health, and the healthcare providers are building within the patients and the community members in terms of taking ownership of their own health. And so getting those questions out inside the exam room is very important, and hasn't been something that's been present down there for many years. So building trust, which we'll probably talk about here a lot tonight within the community, is very important, and especially here in the South. So that's a program that I've been proud to be a part of, and then also helping to increase access to services as it relates to substance abuse prevention and treatment. Several programs have been implemented that I've been a part of here in Middle Tennessee as it relates to helping individuals overcome substance abuse and preventing substance abuse use in many schools and communities. And then lastly, HIV and sexual transmitted diseases programs I've been a part of, helping to increase access to services as it relates to testing for HIV, also helping individuals to practice safe sexual behaviors. So lastly, I would just like to say I see my work in terms of evaluation and helping to improve health health and well-being and being able to use evaluation as a key component to help get us there. I believe working with community partners, health providers, and also different organizations, and coming together collaboratively to help promote health equity. And so with that said, we're going to be talking a lot tonight about health equity, and I'm going to turn it over to my co-presenters, and I look forward to having more of a greater discussion with you tonight.
Well, it's great to be here with everyone tonight to talk a little bit about our team's work. As I was thinking about tonight, I always think back to patients that have come through our program, and one in particular is pretty striking to me. A woman was in our clinic and was recounting the first time that she sought care. She had an opioid use disorder, and she was in for her first ultrasound. And the sonographer said to her, "What are you going to do with the baby? People who use drugs never end up with their babies." That was her first interaction with the healthcare system. And she fortunately found us, and she was telling the story as she was holding her 15-month-old baby. So this recovery is possible. The systems, however, are often put in the way to make it more challenging. And it's as if it's a foregone conclusion that moms are going to die from overdose and infants are going to end up in foster care. So that's kind of sets the stage for some of what I'll talk about here today. So if you pay attention to the news at all, although I feel like it's harder to break through these days, the opioid crisis continues to have a substantial impact on our community, including in Davidson County. During the pandemic, we saw a rapid spike in overdose deaths. We're now north of 110,000 deaths in the last year. 110,000 deaths. It's an extraordinary amount, and it's now getting more complicated. What started first as prescription opioids, then became cheaper heroin that got into the supply, and then fentanyl even cheaper, which is far more deadly. And now we're seeing more stimulant use, and we're seeing the drug supply complicated in some communities with new substances like xylazine, which is kind of hitting parts of the Northeast pretty substantially. All of this has been a perfect storm, couple that with the pandemic and its isolation, to really see the rapid spike of what we've seen in our communities. And to really put this home, this just came out about 2 weeks ago. This is the maternal mortality report for the state of Tennessee. And we know each year that compared to white moms, non-Hispanic black mothers are 3 to 4 times as likely to die from pregnancy-related and pregnancy-associated conditions. Different communities, that also American Indian Alaska Native populations and other communities around the country are disproportionately representative in both maternal and infant mortality statistics. This to me strikes me, right? So acute overdose was the leading cause of death for pregnancy-associated but not related deaths. And what does this mean? Pregnancy-associated or deaths within the first year may not be completely related to that labor and delivery hospitalization, but occur in that first year. Consistently in Tennessee, overdose has been a leading cause of pregnancy-associated death. But here's the thing, treatment works, and so we know it works from, the literature's not vague, right? The most common medications to use in pregnancy are buprenorphine, this is also called Subutex, or methadone. And here's what we know that they do. For pregnant people, they decrease the risk of overdose death, relapsed HIV, and hepatitis C. And for infants, they're more likely to go to term and have higher birth weights. It does come with some risk of drug withdrawal. And sometimes that risk of drug withdrawal gets people really distracted, like we're trying to prevent the baby from having drug withdrawal. What we're trying to prevent is a very preterm baby who we want that baby to go to term and have a little bit of a risk of drug withdrawal. So the way I think about it is like this. If you are going through rapid cycles of using heroin, fentanyl, you're going through these cycles of intoxication and withdrawal. And these medicines, they stable things out so that you can attain recovery. It also makes it less stressful for the developing fetus to grow and more likely to go to term. So in a sense, what we're trading is our tiny babies that I sometimes see in the NICU that are born at 25 weeks who are not mature enough to have drug withdrawal for a baby who's close to term who may have drug withdrawal. That's a pretty good trade. We know every step of the way, access to medications is also not equal. So these are some data from our team, led by Laura Hinkhaus, who is a postdoc, looking at data from Tennessee Medicaid. And let me just say, these are not unique to Tennessee. There have been other studies that find really similar things. Among pregnant women with opioid use disorder, non-Hispanic Black women were 75% less likely to receive medications for opioid use disorder, those two medicines I mentioned before. Women in rural residents were also less likely to receive medications for opioid use disorder. Our team also did some work where we basically just had actors trying to get into treatment. We did this randomized field experiment. It was pretty fun, actually, where you were either randomized to be identified as a pregnant person or non-pregnant person. You were otherwise identical. And what we found was among buprenorphine prescribers, people who identified as pregnant women were about 17 percentage points less likely to be accepted for treatment in buprenorphine clinics. These are, outpatient prescribers who can prescribe this medication. This wasn't the same thing in opioid treatment programs. These are methadone clinics that are highly regulated. But here's the thing, where we've seen the huge expansion in treatment recently has been in these outpatient clinics. In West Virginia, for example, there are only 9 opioid treatment programs in the entire state. So this issue with buprenorphine providers is pretty substantial. And you can see Tennessee here too, right? So Tennessee, we see a little bit of the delta between them. The next slide, if I had more time, I'd put up is if people were able to get into treatment with their insurance as opposed to cash. In Tennessee and in Florida, only about 20% of the time were people able to get into treatment with the insurance they had. And it wasn't Medicaid versus private insurance, it was cash pay. So what we found was most of the time in Tennessee or Florida, when you actually got into treatment, you had to pay cash, and the median cost for that was around $250, which is far beyond what many of our patients can afford. The next place where our team really works a fair amount is in the child welfare system, and this was really born out of what our families go through and what we see clinically. We've seen a rapid increase in infants in the foster care system. Today, infants are the fastest growing age group in foster care. They will account for 20% of foster placements this year. Disproportionately, they're placed because of parental substance use. And here's a place where we see substantial racial disproportionality. So we see that non-Hispanic Black infants and American Indian and Alaskan Native infants are overrepresented by about threefold. And so if you put this piece together, when we sort of lay an equity lens over all of this, we see issues with access to treatment. We see issues when it comes to who gets tested for substances in hospitals. We see issues between who gets referred. There's a pretty famous study from Florida where they use urine left behinds. Sounds gross, but it works, to test like what were the differences in substance use patterns, and then how did that tie to referral patterns. And in that study, they found that compared to white women, non-Hispanic Black women were about 10 times more likely to be referred to child welfare. We've also know from national data that infants referred to child welfare for substance use, parental substance use, are less likely to be reunified with their infants. So what are we doing about it? So we started a program called Firefly about 2.5 years ago with federal funding from the Centers for Medicare and Medicaid Innovation. And it really brought together a couple of things that we were doing around improving maternal care and improving infant care. Here's our team, and our team is intentionally, has very different backgrounds. We have a peer recovery-based model where every patient is assigned a peer. We have social workers who help drive a collaborative care model. We have evidence-based care and access to medications for opioid use disorder, obstetrics, psychiatry, pediatrics. We really try to provide services that really meet people where they are and address many of their needs, whether that's food, transportation, and security. To date, over the last 2.5 years, we've had more than 300 pregnant women, and are getting close to around 200 deliveries. This is just like, hey, this is our logo. When we got kind of a little bit of press about this. But I think one of the things we're seeing in this are we're starting to get some data back, and it looks like we're improving outcomes. But we're hearing stories. We've done some qualitative work actually using the CTSA's community engagement studios. And what we've heard is that people just feel seen. Like, some of this is not complicated. It's just being a human being to somebody. And it can be really transformative. And I think that's what we've seen. Okay, I will be quiet. Here is Firefly's number if you know folks who to refer. And then our website is fireflytn.org. Also has information to get there. One of the things I'll say about our phone number is in our secret shopper study. So when you called, you got someone on the phone. We actually did some qualitative work after this because the way people were treated was pretty bad. We had things like, whoa, I wouldn't do that. I won't treat you because you're pregnant. Like crazy things that people, imagine it takes how much courage it takes to call, and then you get that in response. So when you call this number, you talk to a human, almost always one of our peer recovery specialists, who can help shepherd you through the program. And I'll turn it over to Chad.
How y'all doing? That was boring. How y'all doing? Yeah, good. Hey everybody, my name is Chad Curtis, and let me tell you about some LGBTQ2IA+. If you don't know those letters, you can hire me afterwards. I can come train you and your staff on what that means. We're going to talk about equity in healthcare today, okay? I only have 10 minutes, so we're going to go kind of fast on the stuff that doesn't pertain to what I do. This beautiful quote right here I wanted to hit because there is no such thing as a single issue struggle because we do not live single issue lives. If you look at that little up there, cute little thing, like what makes up the total person is not just one thing and one thing that they're marginalized on, right? Inequities are never the result of a single distinct factor. Rather, they are the outcome of intersections of different social, locations, power relations, and experiences. I'm not going to hit on all of these, but you can see some of the LGBT health disparities that we face in healthcare. I'll just highlight a couple. Lesbians are less likely to get preventative services for cancer. Transgender individuals have a high prevalence of HIV, STD, victimization, mental health issues, and suicide, and are less likely to have insurance than heterosexual or other LGBT people, individuals. I get a little nervous and talk fast. And then LGBT youth are 2 to 3 times more likely to attempt suicide, you know? And so we're over-marginalized, over-victimized, and underserved in this community. And then what we don't talk about enough is LGBT baby boomers, right? Most of these folks do not have companions. It was just legal for us to get married in the last 10 years. So we have all of this community that is aging who is experiencing isolation, no companion, and not much family support if they're estranged from their families. So why are we not talking about that? And then if you look at this little bubble, it's real cute. Today I'm funny too, you didn't laugh. We're going to be focusing on a few different key things here. I will be focusing on lack of cultural awareness, poverty, mental health, and what's the other one? Let me check my little paper. I didn't study enough. I have a full-time job other than that. So I have 2 full-time jobs. I'll tell you in a second. There it is, homelessness. I made this cute little infographic. You can see it out at our table if you did not stop by. I made this for a day on the Hill and speaking to legislators. And when a lot of them came to our table and saw what we did, they made a beeline and walked away because of the state that we live in. It's very sad. They didn't even want to talk to me or talk about this or understand about this. So key thing I want to hit on here is the LGBTQ2IA+ community gets addicted at rates 20 to 30%, while heterosexuals are only 9%. Like I said, we are over-marginalized and underserved. That says 11%. It's actually 14%. So when we are incarcerated, trans people of color get incarcerated at much higher rates. And then when anybody in our community is in the prison system, we're 14% more likely to get raped. We Are One Recovery is what I started back in 2019. And we are the first and only LGBTQ2IA+ recovery residence in the state of Tennessee and surrounding states. And then that last thing I'll hit on, society looks at people with addiction with moral deficiencies, and it's a proven disease model. And we don't talk about that enough. People want to shame people for some of the vile nature of addiction and don't look at the disease model and who the person is behind the disease. Cute. Other little infographic coming. It says 29% of transgender people live in poverty. It says 1 in 5 trans people have been homeless. 100% of my trans clients have been homeless. Statistics do not always match reality, and we do not talk about that enough. And then this key one at the bottom, LGBT youth are 120% more likely to be homeless due to family disownment, family estrangement, for a kid just being themselves and trying to be their most authentic self and being disbanded from their home based on religious persecution. Don't even get me started. We're all professional here, but I got a bad mouth. We Are One Recovery. So back in 2019, I started a nonprofit while I was in school, and I could not get anybody to believe in this idea. I could not get anybody to fund this idea. We had a fundraiser. It popped up on my Facebook feed just a moment ago. 4 years ago, we raised the same amount of money it took to put into the fundraiser to start it. Then the pandemic happened, and then I was like, there's no way that this is gonna happen. And then I was working at one of these hospitals. I've worked at both, I won't say which one. But when I was working there, I was like, I'm not gonna be a cog in the wheel. I am way much more useful outside of the cog. I took out a personal loan for $20,000 and I started this program. It was rocky in the beginning, and we're a 10-bed home in Madison. We now have a wait list of 39 individuals waiting to get placed in a bed. That's not even everybody that needs a bed that's in this community. Earlier this year, we were awarded a $619,286 grant from the Tennessee Department of Mental Health and Substance Abuse Services for the Creating Homes initiative. However, it's a reimbursement grant. Nobody wants to give a bridge loan to a newer nonprofit that is barely scraping by because we pay our bills from people working. We did have a fundraiser in April, and we used that money. We made $4,500. We used that funds to buy the clients a second refrigerator and an air conditioner and repairs around the house. I work full-time as a mental health trauma counselor from home under EAP plans for teachers and government employees. I do everything at We Are One under my spare time, and I did not pay myself for 11 months. And I've paid myself, if you do the math, it's somewhere around $144 a month. As you can see, these are some cute quotes up here from my clients. I did not hold a gun to anybody's head. I just said, would y'all want to say something? And these are some amazing words that nobody got free rent or anything. So that is a cute picture of the house. That rainbow I added myself. It's funny. So when I celebrated 7 years clean, we did it outside, and somebody like tapped me, and they were like, "Look, it's a rainbow." I was like, "God loves the gays too. Come on." So I want to read y'all our mission statement because it is profound. We Are One Recovery's mission is to assist LGBTQ plus individuals and allies with having a safe place to live, free of alcohol, drugs, and persecution. We are inclusive of all people, providing a safe, judgment-free, and bullying-free space. We are a client-centered community, living by spiritual principles and teaching healthy life coping skills to help individuals set and exceed goals. With our deepest empathy, guiding integrity, and loving compassion, we inspire individuals to raise their quality of living and reach their maximum potential. Our vision is that no addict anywhere dies from addiction and no LGBT person ever lose their life to discrimination. This is something I'm very passionate about because I never felt understood, heard, seen. I've been bullied my entire life. I've been picked on. I've done everything that I said I wouldn't do in addiction. I used every drug that I said I wouldn't use. And even coming into recovery, 100% of my clients have been discriminated against in other rehabs and halfway houses. I had a 65-year-old trans woman say to me one day, I was taking her to pick up a check, and she said, "This is fucked up." And I said, What? She said, "Nobody in my entire life besides you has loved me." And so that's what we're doing. We're providing love, hope, and a way out. Here's a review of some terminology. If you don't recognize one of those words in there, hire me, a rainbow advocate educator, and I'll come train your staff. Why do we need to create an inclusive environment? So let me ask you this. With your intake forms to your clinic or doctor's office or wherever, does it just say female and male? Do you have an other spot? Do you have somebody on staff that feels comfortable enough to provide one-on-one care? Are you asking necessary or inappropriate questions? Because a lesbian does not need to be asked if she's pregnant. If you're unaware of this, you need to hire We Are One Recovery. I do want to hit on, no, I'll do that later. Let me say this. This is the reality. Not just in Tennessee, mainly in Tennessee, but all over, right? Life is not about equality. It's about equity. And together we came here for a single purpose, to talk about equity, to talk about how to make things more fair for all, and we can move toward liberation together. Do me a favor, take out your phones. Take a picture of that. If you know anybody that needs us, night or day, even if we're full, I will answer my phone and I will help them. If you know, all you got the social medias, give us a like. We're going to have a fundraiser coming up. Invite your rich family members. We need lots of support. And thank you for your time and attention today.
That was awesome. I want to thank all three of you for being here this evening. And as you saw, there was a thread, right? A similarity. Whether it be thinking about substance use disorder, whether it be thinking about the vulnerable populations that we all serve, right? Each of you are working with and serving vulnerable populations. Now's your time to ask them questions. So I'm going to come up on the stage, even though I don't want to. Chris is making me do this. But there's a mic there. And I want to make sure that the folks, that they have mics as well. So let's make sure that our speakers have a mic up here. Because I think, perfect, great. I think one of the things that is really important, again, thinking about the work that we do when it comes to equity, it really does mean dismantling a lot of issues. And actually, so Chad, I bring my sparkly phone. Yeah. Chad has sparkly. This is me. I'm going to put this right in here. So here's what I want to do. I want to start, we're going to move this way. Tell me a little bit about building trust in the community you work with, right? In the communities. Because again, Dr. Brown, you're working with patients with HIV. You're working with Black and brown communities, right? Hispanic communities who oftentimes experience a lot of discrimination that Chad just talked about. Tell me a little bit about your process in terms of building trust in that community. And I want to ask each of you to answer that question.
Hello. Green button.
Here.
Yeah.
So I'll speak from the standpoint of research and building trust. And from my experience, it's very important to have members of the community involved in the work that is being done. So what that looks like is involving members of the community on the front end, programs being developed, questionnaires and surveys being developed, and also intake forms being developed for people to be able to say that this represents our community, what you're asking, and what you're planning to do. So building trust is very important, the community having their footprint in their hands in what is being done. Oftentimes that step is overlooked many times, and when it comes time to get out in the community and implement a program, if that involvement isn't a part of the program on the front end, you'll see that the program, that the community is not receiving or recepting the program as you had hoped. And so, what that means for my purposes as a researcher, a lot of our numbers that we try to recruit and reach, they take a dive just because we just hadn't thought out the process on the front end, which entails involving community members. And when you have a community member involved, they can help to build trust that is needed to help bring people into the program. So I think that's kind of my a way of working to build trust in the community and having someone involved on the front end to implement programs.
So I think, like, how do we become trustworthy? Like, how do we design systems that are there to serve people? And it turns out not everybody has great experiences in the healthcare system. I mean, raise your hand if you haven't had a bad experience in the healthcare system, right? And no one raised their hands. I mean, like, right, healthcare can be challenging, especially for our patients. And so for us, I think a key to becoming trustworthy is listening. I think our peer recovery specialists have been transformed in the way we think about designing programs. We have an external advisory board, too, that includes people with experience, includes community partners, that we really try to design programs to meet people where they are and change it from the way we do intake, which can be completely overwhelming, and really trying to design programs and be nimble. And we've honestly used the quality improvement approach to just like, all right, let's just change this again and kind of evaluate how things are going. And then along the way, for us, like intentional training, whether that's trauma-informed training, Tavis just did some training for our staff today for people who supervise peer recovery specialists. And so I think part of it is acknowledging the problem and taking honest steps to try to remedy it as best you can, knowing that you are going to mess up, and trying to listen and being thoughtful and humble about these things.
And acknowledging when you make a mistake, right?
Absolutely.
It's okay to say, whoops, right? Screwed up.
And in fact, I would say it's imperative. Having the confidence to say, we screwed this up, because people know when it turns out, right? People know. It's like my kids trying to fool me, right? Of course.
Yeah.
So, relationships. Relationships are key for trust, right? So I'll speak from my perspective. I had a newer client, and she was just bucking the system on everything. And I sat down with her, and I was like, this is what you've got to do. This is what you should do. This is what we got to do. And it was just more this, you know what I mean? And thank God I had Jason there with me, and he was like, stop badgering Chad for a second. Let's talk. And I just talked, on a human level. And I related. And we ended up crying and just holding hands and just connecting. And since then, it's like, hey, how are you? You know what I mean? Just the whole demeanor changed because she's never felt, she had these walls up. And she felt the whole world was against her. And I was just another person that was against her. And I just try to break down those walls and let her know that I want you to succeed. That's all I want. I'm not here to cause more damage, more harm, but you do have to change your behavior. And that built the trust.
So you actually said something really important. That word relationship, and I say this even to researchers all the time, right, who want to do research studies. It's not sufficient for you just to pop in. That helicopter research has gone away. When you're talking about communities that have been disenfranchised, who really have been marginalized, it's really imperative to build those relationships. And that means just showing up and being present, right? Because it's the right thing to do, not because you want them to fill out a survey, right? Which kills me oftentimes in academia. We do that over and over again. And so I think that it's really, really important. Don't forget that mic is open. I want to see some of y'all come and ask a question. But I'm going to ask you this, Chad, because I think one of the things that is hard, particularly when we're coming from a big institution, right, that has oftentimes, unfortunately, participated and marginalized and disenfranchised. Answer me this question. Has anybody at your staff, anybody at your house, anybody ever been ill-treated in the medical system?
Just 2 weeks ago, we were at one of these hospitals. I will not say which one because it doesn't matter. A trans woman, I took her to get some blood work. She's having surgery this week. The phlebotomist came out, called her name, and she walked up, and it's her dead name because we're working on a legal name change. And she told her to go away. I'm not talking to you. Then she spells the last name because she couldn't say a simple last name, the phlebotomist. And she goes back up there again, and she says, yes, this is definitely me. And then she takes her to the back, and the phlebotomist comes back out and starts giggling with the front reception and pointing. And that is so traumatizing had she seen them. You know, like, she's just there to live her life and be healthy. Why create a new barrier? And one phlebotomist is obviously not the representation of an entire organization, but we have so much work that we need to do to address these small things. My other trans woman, so we have a partnership with Thistle Farms. And through Thistle Farms, we just created this partnership, and they're allowing 2 trans women to go through their program while living with us, while I do sensitivity and inclusivity training with their clients and their staff. Because they've tried this before, and it failed. And so they want to do it right now. And so one of those trans women is going to an IOP program, intensive outpatient, for rehab to get more information about substance use disorder. So they have a partnership with the next door. And she called and set up the appointment. And then somebody called back and said, we do not accept trans women. And then she called back and somebody else said, okay, yeah, we do. Come on in. And then she got there and they said, no, you need to leave. How disheartening to a person that has been outcasted her entire life to say, we can't treat you based on, you know. And so she did get let in after somebody at Thistle Farms raised came. But that's not the point. You know what I mean? We created so much more harm that wasn't necessary.
Right. And you know, it's something that unfortunately, if you have excess melanin or extra melanin, I won't say excess because like, I love my melanin, right? But we experience that too. It's Black individuals. If you speak a different language, if English isn't your native language, there's oftentimes these barriers that get thrown up for no reason, right? Other than other people's bigotry. And it's one of these things that we need to work together on. And this is where, again, the research is important. How do you do that effectively, right? And I'm going to come to you, Dr. Brown, because this goes to the evaluation piece, right? It's really hard sometimes when we're doing programs where we are trying to shift behavior, right? Behavior, you're going to say, how do you measure behavior? What are the things you do? Talk a little bit about the importance of evaluation in kind of thinking about setting up programs like Firefly or We Are One.
Yeah, a great point that you make in terms of the importance of evaluation. A lot of times, evaluation is just an afterthought, and it's not as well received by a lot of the program staff and the healthcare providers. It's just one other thing that has to be done, right? And so my job as an evaluator, researcher, is to continually to express the importance of evaluation. Many programs, after it ends, they want to continue on sustainability, and they want to receive funding to be funded. And so, you know, again, my job is to remind them that, hey, if we want to be able to show that this program is effective, and it should be funded beyond receiving funding from the government or some other source, that, hey, we need information, data, to be able to show that we need to be here for a long time. So again, the role of evaluation is very important. It's not easy work. It requires everyone chipping in and being willing to go outside their day-to-day roles and responsibilities to help collect information so we can demonstrate the work that we're doing and how effective the work is that we're doing. So, great question.
And I love the fact you talked about sustainability, right? Because it's really key, especially for programmatic work. We think about it as researchers all the time. We write grants, right? We want to kind of make sure we're maintaining our labs and that kind of stuff. And so we do it all the time, and we think about ways that we can measure effectiveness. But when it comes to programmatic work, and that's my specialty, I will write a program in a heartbeat. Because I love it. It's much easier sometimes to write an NIH grant to say, look, this is what I want to do. And it gives you wiggle room to actually do the community engagement that's necessary to actually do the work and say, oh, we made a mistake, let's pivot, right? It's much harder to do that with an NIH grant, right? So I love that. Thank you for bringing up the evaluation piece. And hopefully that mic is on. Check and see, make sure it's on. All right, you might have to press the little button that's on there. Well, I don't know.
Where that light is.
No, it's on the body of it. Sorry, I must have put it in backwards. That might
No,
be
there's
my
a
fault.
little red light on.
Thank you. Thank you.
All right, so I was the brave one to be the first to ask. First of all, let me just say thank you so much for sharing your contributions in the community. I think as a person in research, this is very useful to me, and it helps me do a better job as we engage the community throughout our work. One thing I am curious about as part of the research process is I feel we don't do as good a job communicating back to communities about the work that we engage them in participating in, to let them know exactly what we found. Just tell the story back to them. And so as an evaluator, I'm curious how much of that dissemination piece factors into your evaluation, or you know, what are your thoughts on that in terms of what you've evaluated in programs? Is that a part of the process, and then how much of that factors into your evaluation and results back to those programs? And as community members, what's been your experience when you're engaged in research? Have you ever been involved in a forum where those results were communicated back to you, and what does that look like? Thank you.
Great question, great question. Dissemination is definitely an area, has become widely talked about, especially in research and evaluation. So oftentimes when I'm working with the program, I like to think about dissemination on the front end and what the program will be doing as it relates to dissemination. And so many people think of disseminating the information at the end of the program, right? And that's something, you know, we want to get away from, right? And we want to feed or communicate the information back to the community on a more timely basis, right? And so what I like to do is come up with a plan, dissemination plan, which may involve you know, communicating our findings through different media outlets that may entail, you know, putting our findings in the newspaper or online or on the radio station or putting a billboard throughout the city to communicate our findings. And then also the data dashboard systems that you're seeing more and more about coming to fruition that many funding agencies are starting to fund. And so a lot of the evaluation programs that I'm working with are developing data dashboard systems in which community members will be able to access to look at the data within their community and be able to see the work that's being done in real time. So again, the dissemination plan is key on the front end, and that is one way, you know, communicating the information, you know, it's what I've been involved in. So.
Steven, do you want to weigh in a little bit on that? Because I have thoughts too. I always have thoughts, but I want to.
Well, I would say so. A lot. Sorry, I'm doing this all right. So we think a lot about dissemination, particularly in our research. So we do, you know, policy relevant research. So we generally have a press release, an infographic. Like think about social media and think about ways to directly communicate to policymakers too, depending on what we're doing. So we are, in our center, if you check out our center too, I should put the website on there, the Center for Child Health Policy, it's childpolicy.org. We're in our 5th year of polling Tennessee parents to understand what are they worried about for their kids, And there, last year, we talked about everything from food insecurity to mental health to school safety to community violence, so cyberbullying, and so we're doing it again now. So we've done this for 5 years. And intentionally, that is, our questions and process are informed by parents. We poll parents, and we're statistically representative to talk about parent voices for Tennessee kids. And so we think about that a lot, like, you know, how do we sort of get things out? I do think, like, in terms of research, like, who knows if this figure's made up, but I'm just going to say it anyway. Half of research is you know, only read by the authors and the editors, right? So you have all these, like, we do all this research, and it goes nowhere. And you know, like, right? You can go back and look at, like, the graveyard of my papers and stuff. But we do it for a purpose. Like, you know, I wasn't like a kid in elementary school saying, I want to write grants for a living, right? I mean, you want to do something that fosters change. And so that key piece of disseminating findings, some of it is like directly to the press, some of it has to do with relationships. Like, hey, have you seen this? With either reporters or policymakers, just to try to, so for example, we're in the field right now asking Tennessee parents what they think about the state refusing education funds from the federal government. We'll see what they are. I mean, last year we polled things like, what do parents think about Army teachers? And so we released, you know, what parents wanted. We actually polled before the Covington shooting, and we had data on what parents think about it. And we saw both sides of the aisle pick up the data, which was our goal. We want to elevate the discourse about what we're talking about.
And let me just share a little bit, and I appreciate what you said, Dr. Brown, about making sure that we're not just waiting until after the study is done, right? Sometimes it can be 5 years done. Right? You know, it's going to be the same community. So one of the things that I've done, I love to do town halls. I think that that's a real important way of getting material information back to community members, right? So I love to do qualitative research. I'm a biochemist, but I do a lot of qualitative research, right? I love to sit down and talk to people and figure out what they love. But then I kind of say, hey, let's report that. Let me share with you what we learned. And we get them, and then we have roundtables, and then we get more information, right? So it gets people excited about being a participant in research when they know that information is coming back there. So I just wrote a tutorial grant where I actually wrote an iterative process where we actually do community engagement studios, right? Everybody talks about community, no, stand right there for you. Community engagement studios, we talk a little bit about that. But doing it iteratively. Don't just wait at the beginning and say, let me get your opinion. But do it iteratively. Say, what do you think about this? What do you think is the best way to disseminate, right? And get the community engaged. I want Chad to answer, because I don't know if you've been involved in research, have you been on that side, and what do you think about the importance of dissemination?
Absolutely, thank you. Yeah, I've been involved with research. If you take offense to this, then maybe it needs to change. There is way too much, not research. Data is important, research is important, it is necessary, but there's way too much waste that goes into different areas, right? So just speaking from a community perspective, there was a needs assessment created by an organization here in Tennessee that studied for 1 year of what the LGBT community needed. And while they're doing all this, I said, I'll tell you what they need. They need a safe, sober space, a community center. We need a trans help and hope hotline. And we need an inpatient rehab. So after a year of polling everybody, guess what they came back with? An inpatient rehab, a safe, sober space. So why are we wasting funds, and why are we wasting this, and there's so much waste in America. I know it's needed because it's got to back it with data and money, but I'm just going to say this. Opioid is not the #1 killer. It's always and has been big tobacco, alcohol, way behind that. Opioids. Nobody freaking talks about that. Because there's money. No offense. It just pisses me off.
It's 100%. Look at alcohol-related deaths, and let's talk about alcohol is the #1 preventable cause of developmental delay in children too. And you're absolutely right.
But it's backed by big pharma, big money. Right?
It's vaccinating the #1 lifeline risk factor for cancer, right?
Exactly.
So yes. So
sorry, I just get a little passionate. You know what I mean?
Passion is good.
Yeah.
And so here's what we're going to do. We have time for one more question before we actually go into some bingo stuff, right? So Chris is going to come up and tell us about the bingo. And y'all like money, right? Because we have a big announcement at the end of tonight about some money that may be coming y'all's way. So you need to stay tuned for that. But Fernanda, you get the very last question before we actually have a chance to chat.
Well, Dr. Lisa already
already mentioned the community engagement studios. And I just wanted to know from the panelists, how do you utilize the community from the development stages all the way through your program, through your research? How do you use the community in the development stages, in developing your program for your research? And how do, and I've heard, trust, and then disseminating at the end or throughout the study, but how have you done it for the development stages of your program?
Yeah, and I would say in terms of when it comes to research, it's identifying those advocates in the community, and depending on the community you're working with, it could be a faith-based leader who has the ear of many people in the community. It can be someone who's just well known throughout the community who people will listen to. So getting to know who those people are and getting them at the table, on day one is very important. So when it comes to working with the community, I can't state that enough. Just get out there and make sure that they're involved. So.
I would say for Firefly in particular, we have lived experts that we've had even in the development phase that we pay for their expertise, right? We pay them to be there, right? And sort of lift them up. We have a study. So a lot of our work, some of our work is kind of looking at state policy. Like we've got a grant right now that just started a couple months ago that's evaluating child welfare policy, and it's kind of a national study. But we reached out to colleagues that have people with lived experience with substance use disorder who have lost kids in child welfare to be a part of our team. So we work with an organization called Children's Trust, who helps support people. It may be a different person in and out actually, but we have folks who reviewed our specific aims, like gave us kind of feedback. And as we start to get data back, they're going to be, again, part of the process that we have. And we'll include them as co-authors in the work too. I mean, this is part of having the voices we go through and understanding and informing the work, because there's just so much richness to that.
Thank you, great question. So back in 2015, I had this idea, and nobody believed in it, right? So I started something for free. I started the state's first and only LGBT Narcotics Anonymous meeting, because that was free, you know what I mean? And from there, it was packed, 70 people twice a week. You know what I mean? And by when nobody wanted to believe this idea in 2019, and then I did it, then everybody's like, oh, okay, this is real. Like, let me help them. Let me give them money. Let me get involved. But it's still hard to, my 30 volunteers and me do not get paid. You know what I mean? And we do all this in our spare time, but we have a full-time job. And so it's just about finding that access to help people help people. You know what I mean? And we all got bills to pay, but does that make sense how I'm trying to say that?
Yeah. And I think, thank you so much for the question, Frenika. And I do think, Steve, it's really important to make sure we're paying our volunteers, right? We're paying them because they're experts, right? They're an expert in their situation, in their context. I think that's really important. So can we get a round of applause for Thank you so much for sharing your expertise. If you look on the back of your programs, you'll see a list of names. Those are the previous individuals who have spoken. We've had folks talk about diabetes, who come and talk about lung cancer. This community forum is really important because what we want to do is say, look, we can do research together. We can do research that's actually going to impact our community and not be wasteful, right? So part of it is actually really doing a better job. So here's the big announcement. I'm going to do it now because y'all about to play bingo. But
B52?
the Meharry-Vanderbilt Alliance is going to reinvigorate its grants, community grants. We used to do this years ago. But what we want to do is foster real partnerships that are really going to start to address some need in the community. It needs to be community, partnered with someone in an academic setting. And so we're going to come out in the spring is when that request for is going to come out, request for proposals. So we hope that you guys will take this opportunity to meet folks, like-minded folks, or maybe somebody you can partner with. And we're going to require that individuals who apply for this either have attended one of these events. We've had 3 of them. See that catch? One of these events, or there have been a one of our faculty affiliate members. So we do a faculty affiliate program where faculty members from Meharry-Vanderbilt University Medical Center or Tennessee State University can join the Meharry-Vanderbilt Alliance and really gain access to some of these great tools. We want to make sure that the Meharry-Vanderbilt Alliance is seen as convener people, that we are here for our community, that we want to do everything that we can to really move towards ensuring that we have health equity, regardless of the stigma that might be associated with the disease, the population, et cetera. So thank you all so much. Really appreciate you guys. Thank you all for being here.
All right, good evening, everyone. My name is Christopher Smith. I am the Program Manager for Community Engagement at the Meharry-Vanderbilt Alliance. First, I'd like to say thank you to all of our speakers. Let's give them another round of applause. First, I'd also like to say thank you to the NEA team for helping bring this together, and a special thank you to Beverly Fetterman from Dr. Kaplani's office, and also to Dr. Yes, round of applause, absolutely. Also, thank you to Dr. Sunil Kriplani and Dr. Michaela Cook for being kind of the thought partners in bringing this together. So now we're going to get back into some networking. Before I do that, though, I do want to ask you to do one other thing. Please scan the QR code and complete our post-evaluation survey. It should only take you about a minute to do. We want to know your thoughts. We want to continue to improve this event. And then we'll jump straight into networking bingo. So some of you have already gotten a head start if you were here before we got started with the program. But the point of this is not just for this to be a speed game, but for it to really foster conversation and networking. So the way that goes is some of you have already been doing this, but you're looking to match with people who have the traits on your bingo card. Then you have to ask them at least one question on the back of your bingo card. Those questions will also be up here on the screen. I'm gonna put that QR code back up there for now, but I'll put the questions back up in a second. And then you can move on. We have 6 Starbucks, $10 Starbucks gift cards for those who get bingo. So your goal, of course, is to get bingo, but also to network. And we can go ahead and get started now. So whenever you have bingo, you can just yell out bingo, and we'll make sure you get your gift card. Awesome. All right, thank you. Well, everyone, you can go ahead and get started. I hope to be here in bingo for real soon. So, all right, thank you.
I know some of y'all have to leave.